Good morning, everyone.
Good morning.
Very good crowd. I didn't hear a lot over here, though. Good morning, everyone. Good. Well done. Well done. Welcome to today's Voices of Experience conference. Our topic, recovery after disaster. My name is Peter Brown, and I'll be your guide through today's program. This promises to be a very interesting session, and we hope you leave today just a little bit smarter and better informed than when you walked in the door. I'd like to take a moment and thank the wonderful sponsors, the hospitals in regions 2, 4A, 4B, and 5. You know who you are, but if you have a doubt, all 39 of your institutions are listed in the program. We also want to recognize and acknowledge the work of the planning committee for today's conference. Their names are in your program, along with the chairperson of the planning committee, Tina Wright. They put in a lot of hard work, so I'd ask the members of the planning committee to stand so we can recognize and thank them. A couple of more items before we get started. We'll call this your Need to Know section. Those who wish to receive CEUs should sign in, not now, but should sign in at the tables near the registration desk, either at the break or the end of the day. Please make note of the emergency exits. The closest one may be behind you. Come on, airline humor. Help me out here. And I would please ask that you put on vibrate your cell phones and beepers. Does anybody have a beeper anymore? Is that? They do. We do have beepers. Okay, sorry. You know, I have a BlackBerry and my family yells at me, so. And a special note, just to prove the Voices of Experience program is right on that cutting edge. There will be live tweeting of today's program. Official hashtag VOECONF. Huh? How about that? VOECONF, official hashtag. If you'd like to tweet, please be my guest. Twitter, MA Voices of EXP. MA Voices of EXP. No spaces there, please. But here are the rules. You can tweet, but no selfies until lunch break or the end of the conference. Okay, let's get the program started. And that begins with an introduction from Mary Clark from our state's Department of Public Health. Mary has served as director of the Office of Preparedness and Emergency Management at DPH since 2007. In that role, she oversees state and local preparedness and response, and she does an excellent job. Please join me in welcoming Mary to our conference with a few words.
So thank you very much. I appreciate the opportunity again to come and welcome you to this conference and kick off the day. I also want to thank the members of the Planning Committee for the excellent work you have done in thinking about what the day should be. Also want to thank Regina Villa Associates for the work that they do to support this conference. We've worked with them for years in a number of ways, and they make the day happen seamlessly and provide the sort of support that we need to bring all of you together and provide you with information and wonderful speakers. I want to thank the speakers who are here. I think there is a tremendous group of individuals who will bring a lot of information and experience from being on the ground during and after emergencies, so they will provide some valuable information for you that you can take back to your institutions, to your health departments, to all of the organizations that you work with. And then I want to thank all of you for taking the time to be here. It is always difficult to give up a day to come to a conference, so I think this really shows your commitment to looking at your plans and thinking about what you can do better so that you can recover after disasters. When I was thinking about opening remarks today, I was thinking about how far we have come from the early days of emergency preparedness planning back in 2004 when I first started doing this. And we worked very much in silos, and we didn't talk to each other. Even within the health disciplines, we often didn't talk to each other. And God forbid we would talk to emergency management. But over the years, we have seen those silos breaking down. It's not perfect yet by any stretch of the imagination, but we are talking to each other now, and we have recognized the importance of coming together in opportunities like this to share information about what works, and probably equally as important about what didn't work. Because each of us has been through disasters or events where we came upon that gap that we didn't know was there and had to deal with it on the fly, and then have the opportunity afterwards to improve what we had planned for and to respond to that. And that's why I think these opportunities are so incredibly important, to come together and have an opportunity to hear from each other's experience and ask questions and talk about what works and what doesn't work. Last night, I was also fortunate to be at another annual event that brings together people to talk about best practices. We support annually a program through our Massachusetts Medical Society that brings together people from across the state to talk about their experiences more primarily around public health and hospitals. But last night, we saw over 100 people who came from all over the state. We had public health officials from the city of Springfield, we had hospitals from Boston, we had the American Red Cross, we had MRC leaders and MRC volunteers from across the state. And they came to hear and share experiences about what they had done and take messages back. So last night, they got to hear, we talked about Twitter and being cutting edge. They got to hear presentations on the use of social media in emergencies, specifically the Boston Marathon in 2013, as well as the range of emergencies that MEMA is involved in and provides Twitter and Facebook and other social media information. They got to hear from an MRC leader about how useful and important it is to collaborate with other volunteer programs like the CERT program, and how they work together and how they can build partnerships that help support the needs of the residents of their community and learn to work together. They also heard an excellent presentation from a Worcester pastor who talked about the importance of faith-based, and I can never say that, faith-based communities, and the assets they bring and the knowledge and skills that they can bring to planning for, responding to, and recovering from emergencies. And finally, we closed out the night with a presentation on the importance of planning around animals and making sure that we protect all of our community and that we recognize the importance of pets and service animals and other animals to the residents in our community, and understand that if we're not planning for those animals, we're really not planning for the whole community, and we're not doing the job that we should be doing. So we had over 100 people who were there for almost 4 hours last night listening to those presentations and taking messages back that they can incorporate in what they're doing. And I think that is the importance, and that is why we're so happy to sponsor programs like this and programs like the Medical Society, because it is really us getting together and sitting and talking about what we're doing and sharing those lessons that helps us move forward and helps us break down the barriers that may still exist across us. So I'm very excited to listen to the presentations today. We have a group of excellent speakers who are going to bring you lessons learned from their response and recovery from disasters. So I will not take more of the time. I will let you get into the meat of the program, and just thank you again for being here, and I hope that you have the wonderful day that I think you will. Thanks very much.
Mary, thank you for your support, for the support of the Department of Public Health. Now it's time for our first presentation. So let's take you back in time a little bit to the summer of 2011 and the early fall of 2012. A rough couple of years for our good friends in New York. Do you remember the headlines from Hurricane Irene and Superstorm Sandy? First, Irene. She made a total of 9 landfalls in her weather life. Her final one was Brooklyn. Scores of deaths and a multitude of injury and billions of dollars in damage in her wake. For New York, if that wasn't enough, just over a year later, October 2012, on comes Hurricane Sandy. For New York, a disaster. The storm surge was brutal. And right in the middle of it was our first speaker. Mary Parauda has been the director of the VA New York Harbor Health System since July 2010. 3,400 employees covering most of New York City and responsible for the health care of some 50,000 veterans. Martina was in charge during these giant storms, and she is here today to talk about her experience. And time permitting, we'll get a chance to also ask her a few questions. Martina Parauda, welcome.
Thank you, Peter. As Peter said, I'm Martina Parauda. I am from the VA, and I'm very proud of it. As Peter said, back in 2011 and 2012, we suffered natural disasters. Now, in New York City, when we do emergency preparedness, it's usually for terrorism. It's just part of our life in New York City. We're not used to natural disasters, so when they occur, we often poo-poo them. Well, not anymore. So the first picture you see there is Rockaway Beach, part of Queens, literally right on the water, as you can see. And this is as Superstorm Sandy is beginning to really hit landfall. But let me take you back in time to 2011. Those are the three facilities for which I am responsible in New York City. On the right-hand side is the facility in Manhattan. It takes up one city block, it's about 6 acres of land. It goes from 23rd up to 25th Street on First Avenue. On the front side and on the back side is the East River. We go up, we don't go out, typical tertiary care facility in an urban setting. On the upper left is my site in Brooklyn. It also is on the water, but it is up on a hill. You can see the Verrazano Bridge in the background, a beautiful view of New York Harbor from Brooklyn. And then on the bottom left is my long-term care facility out in Queens, St. Albans. It's on 55 acres. That truly is what it looks like right now. In spring, when it's in bloom, it's beautiful, and it's great for the long-term care residents. So keep in mind that I oversee 3 main campuses in New York City. Let me put it into context. Every VA is part of a network across the country. We are part of Network 3, which oversees the southern part of New York and the majority of New Jersey. It's highlighted in yellow there. Most of that area is densely populated. It is New York City. And as Peter said, I'm responsible for the lives of about 50,000 veterans who use my healthcare system, New York Harbor, on an annual basis. There we are, those 2 city blocks. You can see that blue is the East River, so we're not far from it. And that red star you are here is my front entrance on 23rd Street to the Manhattan site. So now, Irene, August 2011 is coming. Now, in New York City, when people say hurricane, we think of the South, we think of anything but New York City. It just isn't part of what we do. Now, my mother is originally from Massachusetts, born and raised, alive and well at the age of 82, visiting her sisters right now in Uxbridge, which is where she is from. She always talked about the hurricane of '38 and how it devastated and to go on. And she was 6 years old at the time, but it left a lasting impression. So growing up, I heard about the hurricane of '38. Okay, Mom, great, hurricane of '38. Little did I know that I would be living through the hurricane of 2011 and 12. As the CEO of a healthcare system, Irene is approaching. Now what do we do? In New York City with Mayor Bloomberg, this was now a media event. And Peter, no offense, but the media does play things up. So this was the be-all and end-all, Irene. And the decision was made by Bloomberg to evacuate. As a federal healthcare system, we are not required to go by what the city and state decides. Federal will trump city and state. So the questions that raised for leadership is, should we evacuate? Because Manhattan is not only serving the Manhattan veterans, It is a tertiary care referral site for surgery, anything cardiac surgery, neurosurgery, high-end vascular surgery, anything really interventional cardiology, including cardiac caths. For that whole region or network that is Vision 3, Network 3 for VA, those patients go to Manhattan. So if you live in New Jersey and need a cabbage done, you go to Manhattan. If you live in upstate New York, you're going down to Manhattan. It's just part of what it is. It's regionalization of care for high-end services so that you have the most competent physicians and nurses who do this day in and day out, taking care of the nation's veterans. And that's what we do in Manhattan. So it's not just shutting it down for my Manhattan vets, it's shutting it down for a whole network of hospitals. Network 3 is adjacent to Network 4, which is Pennsylvania, so we get quite a few veterans from Wilkes-Barre, Pennsylvania and Lebanon, Pennsylvania who come to Manhattan for that high-end surgical care. So all of this is going through my mind. During Irene, I had about 105 inpatients at Manhattan, some of whom were recovering from cardiac surgery and neurosurgery. I had a couple of vent-dependent patients, and Manhattan also has 42 acute care mental health beds. Those are 2 locked units. The highest level of acuity for mental health is actually at my Manhattan campus. So do you pull the plug and say, we're out of here? And that's what goes through his leadership mind. Can you safely evacuate? And if so, where are they going? I've been with VA for about 25 years this July. In 1992, I was at the Manhattan site working. December 10th, we had a nor'easter hit. Within 1 hour, that was the back parking lot of Manhattan. Now, Manhattan VA does not have a lot of parking. Nowhere in Manhattan does anyone have a lot of parking. It's just the way of life. So my postage stamp parking lot, as you can see, the cars were floating. Within 1 hour, literally 1 hour, from 9 a.m. to 10 a.m. that morning, that's what had happened. Now, you'd heard on the news about a nor'easter, but okay, we've had nor'easters before. The Manhattan site is just 4 feet above sea level. It actually is the lowest point on First Avenue. So with the torrential rain and a full moon, everything came together, and that was my back parking lot. Fine, you know, you can recover from a car, but my loading dock is right there, and the water started coming in. And we had 8 inches of water on the ground floor, which is where everyone's utilities always are in a hospital, and it actually shut down the electric and everything else. That was going through my mind. Within 36 to 48 hours in 92, we were up and running. But we had full hospital, all the patients were there because it hit just like that. That left a lasting impression in my memory. So Irene, 1 p.m., our network director had a call with all the directors in New York and New Jersey and say, should Manhattan evacuate or not? Because Manhattan was the only site really at risk in our network. At 4:28 that afternoon, Governor Cuomo declares a state of emergency for New York. At 6:30, I'm at home, and there's the Mayor Bloomberg going on saying, anyone in Zone A, hospitals, you need to evacuate. Well, we're in Zone A. 8 p.m., once again, I have a call with my director, and we decided to evacuate Manhattan. Remember, we did not have to because we're federal. But quite frankly, we look pretty foolish if everyone else around you is evacuating and you're not. So once again, you got to keep in mind what's the appearance going on. But we were a little bit concerned. But there was not a full moon during Irene. Keep that in mind also. So the challenges during Irene, we had never evacuated. The Manhattan facility opened in October of 1954. In its history, it had never needed to evacuate. So here I am doing the first thing of evacuating. And yes, you all practice drills. You know what the drills are all about. And those of you in hospitals, Joint Commission requires it, and we all do the drills. And I have to tell you, as a CEO, not many of us love doing those drills. But I can tell you today as a CEO, the importance of doing those drills, because they pay off. You know what to do. So we had never evacuated. We had 105 patients. As the VA, we have a luxury of being able to evacuate them to the other VA sites. Manhattan is 11 miles from the Bronx site, which is just north of us, and just 12 miles from the Brooklyn site, and 15 miles from Queens. So despite New York City traffic, it is doable to get to those sites. And so as a network, we worked together because I had in-house veterans who lived in New Jersey, who lived in Pennsylvania, who lived upstate, who had come to us for surgical care. If they could safely be transported back to their referring site, that's what we did. Let's get them out of harm's way. Let's get them out of New York City. So some of them did go back to their originating site. The majority of them, however, we had to evacuate to other VA sites. And that's what we started to do. The mayor then announces that he's going to shut down the New York City subways and buses. That's the way everybody gets around in New York City. So it's not just worrying about my patients, it's worrying about my staff. How can I ensure that they safely get home before the hurricane hits? VA has had electronic health record for over 20 years. It is a thing of beauty. And it really does save you when you start evacuating patients to other VA sites because you can pull up that electronic health record on the patient and not miss a beat. You know exactly what the medications are, you know what his course of treatment has been, and it really did pay off for us. And then ultimately, once we evacuated everyone, you have to safeguard your vacant campus. And that's where our federal police officers and our engineering staff come in handy. One of the things we learned during Irene is New York City, when it responds, will respond to the city and for-profit or not-for-profit hospitals before they'll respond to the federal government, because the federal government, they consider, has its own resources. So what you see there are the ambulances lined up along First Avenue, and they're in front of NYU Medical Center and Bellevue. NYU is the not-for-profit, which is my affiliate through the medical school, and Bellevue is the city hospital, the trauma center for New York City. And way there on the right, that brick building is VA. They did not come to us. Matter of fact, one ambulance came up my ER ramp and said, "Is this Bellevue?" We said, "No, it's the VA," and they turned around and went back up to Bellevue. So we were reliant on our contract ambulances and ambulettes. Now, they came through for us, and other VA sites in the area actually have their own ambulances, so they came and brought them and carried them where they needed to be. But it took us longer to evacuate. The other thing that we kind of perfected through Irene was a tracking system for all of our patients. We downloaded the inpatient roster onto to a spreadsheet, and 2 people were assigned to track every single patient as they were going from SICU up to the Bronx. They left, they got to the Bronx safely. Doctors and nurses often accompanied the patients in the ambulances depending upon acuity. I also have a shuttle system because I'm a multi-site campuses. We have our own shuttle system, and so the mental health patients who are ambulatory were able to go in shuttles with the nurses and doctors in there and go up to the Bronx site where they were going. So it was quite an experience in Irene. We did it safely. And that was the morning after Irene. My parking lot was worse after the nor'easter than it was after Irene. The same parking lot, and you can see the water. We suffered no damage due to Irene. And within 48 hours, all my patients who needed to come back to Manhattan did. Those who could be safely discharged from wherever they were safely discharged. So the components of success, we really work together as a network within VA. It's true of every network across the country. Our medical school affiliates, which are New York University in Manhattan and then State University of New York downstate in Brooklyn, they came through. The residents went wherever they needed to go for patient care. The unions were not a problem. They worked together. The employees did not give us any problem. Veterans and families were very understanding of the need to get out of harm's way. Communication, we all know you can never communicate enough. Email, social media, we did tweet, we were on Facebook, and constant situation updates into central office, into the secretary. So Sunday morning, New York Times comes out. Most New Yorkers emerged to find little of the widespread devastation the authorities had feared. And quite frankly, that was our undoing in New York City. Irene was a great dress rehearsal for Sandy from my perspective, but unfortunately for most New Yorkers, it was like the little boy that cried wolf. So 14 months later, October 2012, and guess what? There's a full moon. So you know what I learned from 1992. So here we go again. So the governor declares another state of emergency on that Friday. Saturday, I'm actually driving from upstate New York. I dropped my mother off with friends, and I'm listening to the radio. I'm thinking, oh, this is not good. Friday, what appeared to be, okay, we might be, able to stay. As I'm driving back Saturday, I'm saying, this is not good. I walk into my house, the phone is ringing, and it's my supervisor, the network director, Mr. Sabo, and he said to me, Martina, it's your decision. You're on the ground. Tell me whether you want to evacuate or not. I said, we've got to evacuate. We just have to get out. I said, that full moon just doesn't sit right with me. So all the calls went out that night across the network and to all of my staff across New York Harbor, more or less saying, report to work the next morning at 8 a.m. We need to evacuate. And at that point, we had 127 inpatients at Manhattan. The mayor announces we're going to shut down the subways and buses at 7 p.m. Is this becoming a little bit redundant? It was. But the difference was the mayor never ordered the evacuation of the hospitals in Zone A, which is the zone adjacent to water. He ordered the evacuation of residents from Zone A, but not the hospitals. And when asked afterwards why he did not order it this time, he said, the hospitals have assured me that they can withstand whatever might come with Sandy. Now, they didn't call me, but remember, I'm federal, so they're not going to call me. So there we are. That is my back lot. That's Manhattan. We go up and out. The other thing that we do have at Manhattan is research, a lot of research, including animal labs research. We learned during Irene, you evacuate not only humans, you evacuate all those four-legged creatures as well. And that's what my research techs did. They came running to me during Irene saying, we got to get these animals out of here. Okay, good, go for it. And they did. And from Irene, they learned that there actually are companies out there who will securely transport animals during disasters. And so we contracted with them after Irene. So when Sandy came, we called them, they came, and safely transported my animals to my animal lab at my Brooklyn site. There's the aerial view. So that big complex is Manhattan, RVA. You can see the FDR Drive runs right along it, and then you see those boats, they're in the water. They're in the East River. So you can see how close we are to them. Monday night. Sunday we evacuated, everyone got out, everyone was where they needed to be, including my employees. And you can learn a lot of things from your frontline employees. I had a lab employee call me on Sunday as we're evacuating. Martina, when do you think we can shut down the lab? Now, what do I know? I mean, I'm a CEO, and yes, I'm responsible, but I'm not a lab person. I said to him, well, what do you think we should do? He said, well, if you do the last blood and urines by 3 p.m., I can get everything processed into the electronic health record, and then we can be out of here by 6 p.m. and I can get the subway. I said, that's it, that's what we're doing. And he did it, because you draw them at Manhattan, you do the runs, you just put the results in the electronic health record. When you get to Brooklyn or Bronx, they're there for you. You're ready. One less step to do with the other sites. Food. We learned in Irene, people live for food. Okay, you didn't know that. So my patients were, okay, are you going to feed me before you evacuate me? And I had one veteran say, I'm not leaving until I get a hot lunch. So you've got to live with human nature. You understand what they're going through. No one gave me any back talk about evacuating. It was how they were going to and what amenities were going to be with them. And we learned during Irene, and this was without me saying do it, the food people packed bag lunches. In case they missed their meal tray coming through, they would have a bag lunch to go with them wherever they were going. Nurses and pharmacy worked together to bag medication so that no patient would miss a dose. If they got to their new place a little bit late, their meds were with them. The nurses had them in the bags, marked with the patients, they went with them. All of that we learned during Irene and were able to implement during Sandy. So everyone's home safe except my incident commander, who's my chief operating officer, stayed on site with the police officers and with my engineering people who thought they had fortified the site. We know that we didn't, and at 7:45 p.m. on Monday, I'm on the phone with my incident commander, and they're batting down the hatches, they're outside, and all of a sudden, she says to me, "I gotta go." I said, "Where do you gotta go?" She says, "We gotta get out of here, here it comes." And I said, "Here comes what?" And she said, "The tidal wave." And that was it. I found out later they were running for cover, literally running up stairwells, because a 13-foot surge of water had come over from the East River onto the campus. There's my ground floor, 4 to 5 feet of water, not the 8 inches we had had in '92. And you can see the water line in the picture on the right. Needless to say, all my utilities were completely gone. By the next morning, the water had receded, but all of the damage had been done. Every major utility used to run a hospital was completely shot. The building was structurally sound, but not usable. And you can see the list there. Anyone who runs a hospital, this is the stuff that you have, but it was no longer usable. Brand new fire alarm system, hadn't even been commissioned yet. And all that green is that lovely salt water from the East River. Completely destroyed it. And they all look like, every piece of equipment looked like that. And people said to me, "Why didn't you have them up?" Well, see those are my generators. They were up, didn't matter. You can't get anything up high enough on the ground floor, on a basement level. You gotta get things up on much higher floors. My sterilizing, my processing for the OR, any procedures, all those instruments that you sterilize, there they are, completely gone. All the steam sterilizers were shot. All my primary care and medical specialty clinics were down on the ground floor. They were in actually a building that had been built in the early '90s. State of the art for outpatient care. 150,000 square feet was completely underwater. And that are the pictures of the day after. You couldn't even keep track of where you were. MRI was also completely ruined. It was on the ground floor back in the '90s when it was put in. Everything, MRI had to be down on the ground floor for weight-bearing purposes. It was completely ruined and actually was somewhat dangerous to go near. The amount of water that got in there and what it did to the MRI was incredible. I mean, you didn't even recognize it after a while. From my perspective, I just want to enforce, setting goals is very important. What are you going to get accomplished and when? And I'll show you how we did that for recovery. Don't be afraid to ask for help. One of our speakers is from New Orleans, and I was sharing with Sunday that we called the New Orleans people and said, "Okay, what did you do?" They said, "You got to get the mold out. Don't let mold grow because it will ruin your building. Even though you're structurally sound, it will ruin the building." And so within a week, we had a contractor in literally getting all the walls, everything down the ground floor came down except the structural steel. And I was there when we built that clinical addition in the early '90s, and I never thought I'd see that structural steel again. I was wrong. So they removed everything and bleached everything you could possibly imagine. The communication factor, you cannot communicate enough. And you have to be flexible, because things that you think are the right thing to do sometimes need to be rethought. What you think is going to work for a patient may not work. There's my structural steel in that outpatient building and the clinical addition. And in that clinical addition, the ground floor was all outpatient, but the fourth floor was all my OR, state-of-the-art 10 ORs. So nothing was usable at all in that entire campus. So first thing we did, come up with the timeline. Okay, when can we get back in, and what do we need to do to get back in? So outpatient care was different from inpatient care. Inpatient care, you have to worry about if you have someone sleeping overnight, it's a whole different set of regulations kick in. Outpatient or a healthcare occupancy, business occupancy are very different things. So we came up with, what do we need to have outpatients back? And there's the list in front of you. What can we do? Now, we weren't going to put them back down on the ground floor. I made the decision up front, nothing patient care related is going back on that ground floor. I have upper floors, and we started moving people around. Remember, I've got 1,500 to 1,600 employees who cannot come to the Manhattan campus to work. Matter of fact, once you get into the main lobby, it was complete darkness. It wasn't safe to be in the building. When I came in the next morning, they handed me a flashlight and a hard hat. And when Secretary Shinseki came up the next week to see what was going on, we handed him the flashlight and the hard hat. And it's amazing what seeing is believing. Those of us who are doubting Thomases, it opened your eyes as to what damage really was done and how unusable that building really was. So we said, okay, outpatients, which is the majority of what my 20,000 veterans at Manhattan come for outpatients. So let's set a timeline of what we need to do. The first thing we did was, okay, how are patients and employees going to know what's going on? Some of them have been devastated by Superstorm Sandy. It's not just the medical center. There were people who lost their homes. They went out to sea, literally out to sea. And there are people who were living with relatives, living in hotels, and it went on for quite a bit. How are we going to get in touch with them? As I said, we used social media. We also established a round-the-clock call center for both patients and for employees to get information about what was going on. My primary care physicians knew who their panel of patients were and knew who they were worried about the most. And through the electronic health record, they were able to pull up their phone numbers. We ask every veteran, if you have a cell phone, please give it to us. And in addition, VA has an email, a secure email system for veterans. And if a veteran opts in for that, we can securely email them. Now, usually we use it to give them the lab results and can take any questions from veterans that they might have. We never thought we'd have to use it for disaster. But that's how the doctors were able to get a hold of many of their patients. So the doctors were literally just taking lists of who their patients were and contacting them. They also, the medical staff took the lead in setting up clinics, care at other VA facilities, the Bronx, Brooklyn, and Queens. And at some of my outpatient clinics in the community, the main one being in downtown Brooklyn. So it was the medical staff working with nurses. What do we need to do? How can we do it? And all of VA as a family worked together to do that. But veterans kept showing up at Manhattan. And I'll never forget, it was a day in February. I walked back from the Brooklyn. I would start my morning and end my day in Manhattan every single day just to keep tabs on what was going on in recovery. And I'd spend most of my time at our Brooklyn or Queens site. And I came in one afternoon from Brooklyn into Manhattan and into the lobby. And there's a veteran there, and he looks around and said, "What happened here?" And one of my police officers said, "Well, we suffered damage from Superstorm Sandy," which, remember, was like 3 months earlier. But you think you're communicating, but there are still people out there who don't get that message. It's just not on their radar. So when he came in and we said, you know, we're closed, he said, but do you still have that shuttle to Brooklyn? Yes, we do, sir. But because veterans kept showing up at Manhattan, the medical team put a triage right there in the lobby. You couldn't go beyond the lobby, but they were right there at the front doors. It was my ER physician, psychiatrist, which is always key during any disaster, but in VA, it's a large part of our population, veterans with mental health diagnoses. There was a pharmacist and a social worker. The social worker was key because now veterans who had never been homeless before were homeless because of Superstorm Sandy. So they needed resources available to them. That group of 4 were there from early November until we completely opened up in the springtime. And that really was key because veterans knew they could still get their care. It may not be in the way that they were used to, and it really was meant to triage, and if someone was really acute and needed to go to a hospital, we'd put them in an ambulance and send them to an open hospital outside of VA. We weren't going to monkey around. It's just whatever the veteran needs, that's what always comes first. Many of them needed pharmacy renewals, you know, just needed some kind of information, and some just needed reassurance. But that quadrat of people really was key. So what do I do with my OR? Since I'm a surgical referral center in Manhattan, we opened them up at Brooklyn. We expanded the number of ORs. We had 6 ORs at Brooklyn. We were only using 4 of them. We opened up the other 2. One was devoted to cardiac surgery, and one was given to the Manhattan staff for others. They worked very closely to the surgeons and the medical staff to ensure that every patient who needed care was able to access it at Brooklyn. The mental health inpatient unit actually opened up at the Bronx. They had the space available for us, and they went. And those of you who have affiliated medical schools, I have to say, NYU and SUNY Downstate worked with us every step of the way. And the residents were told, wherever the patient is, that's where you will be. And those who are doing their VA residencies, if you're in Manhattan at NYU, you do an NYU, a Bellevue, and a VA residency. It's just part of the overall program of the NYU residency. So if you were on your VA rotation, you went to wherever your VA patients were, whether it's Brooklyn or Bronx. And they did it without missing a beat. ACGME, the American College of Graduate Medical Education, which oversees all residencies in the United States, quickly had called NYU right after the storm to find out what was going on with the residency programs. Because NYU and Bellevue had closed. They're the two that actually evacuated during Superstorm Sandy. They're the ones who really made the headlines because they were the heroines and heroes during the actual storm. But they were closed. So they were scrambling to place their residents at other hospitals throughout New York City. But if you were on your VA rotation, it wasn't a problem. You just went to the other VA site. So they worked very, very closely with us, and the residents were able to complete their residency without missing a beat. At St. Albans in Queens, which is my long-term care facility, we actually opened up additional nursing home facilities because there were patients, veterans, who no longer had a home to go home to. So we were able to accommodate them to the best of our ability out at the long-term care facility. And to free up acute care beds at Brooklyn, someone who was in an alternate level of care, not quite ready to be discharged but not needing acute care, would go out to St. Albans, Queens. So there were a lot of things that we had to work through with our population. We did have mobile health units from the other facilities. They parked them out front. We didn't use them as straight clinics necessarily. We found, what the doctor said is, we really need the blood draws, the anticoagulation clinics, and all of the vaccines, because it was flu season. So flu shots and all the vaccines. That's what we need to be done right there on site, and so that's what we did. Research, we temporarily established it at our Brooklyn site, and that worked out well. NYU took a big hit because they were not able to save their research animals. While they're evacuating during the storm, obviously it was human life first. So they lost millions of dollars worth of research due to Superstorm Sandy. So we set a timeline that by April 1st, all outpatient care would be back at Manhattan. We actually beat it by just a bit. By the end of March, everyone was back. We got most utilities up and running that we needed for outpatient care. We started returning in phases because we needed to test the waters. We thought it would work. Well, no pun intended, would test the waters. We thought it would work, but you don't really know until the patients are back and the staff are back saying, wait a minute, what about this? What about that? So we're back, and we're back in March. We're beginning, okay, next is the ER and inpatient care. So we started planning for that. And meanwhile, shortly after Superstorm Sandy, Congress approved $207 million specifically for the VA at Manhattan so that it could be bolstered up and brought back to whole. And that, I have to say, is due to Secretary Shinseki. When he came up and saw the damage and was speaking to us, he said, this is a flagship facility in VA. We need to make sure you are modernized, state-of-the-art, and have everything you need. May 13th, just over a year ago, we were fully back. The ER opened, inpatient units were open, ORs were up and running, and this was a bit of a discussion, I'll say, I had with the medical staff. The medical staff wanted to bring back whoever the New York, Manhattan patients were from the Bronx and Brooklyn, bring them back to Manhattan. And I said, but why? They're not the same patients we evacuated. Why are we sending them back to Manhattan when their care has always been at the Brooklyn and Bronx? Why don't we end their care, discharge them home from there, and only admit new patients through the ER or planned admissions into Manhattan? They had a lot of pushback to me because of the residency program. Well, the residents are assigned, patients, et cetera. I have to say, the NYU and SUNY downstate residents worked it out on their own, and they covered for each other so that one of the NYU teams was freed up and went back to Manhattan, and a SUNY team would cover their patients, still meeting all of the Bell Commission hours for residents. So I have to say, they did a beautiful job working it out, so we never transferred back a veteran because they weren't the ones who were there to begin with. So now, we're building the major project, the $207 million. We're getting a seawall. It will be 10 feet high. I said we're going to be a fortress. That's what we're going to be as a medical center. And 10 feet high, you would think would do it, right? Well, I still have my doubts. So everything on the ground floor is being relocated. All the utilities are going to upper floors or onto roofs. As I said, no care will be downstairs, so all the outpatient care that was there will be up on upper floors as it is right now. The MRI was actually going into the rest of radiology, which is on the 6th floor, and we're not getting one, but we're getting 2 state-of-the-art MRIs. We are rebuilding all of sterile supply. The chapel is actually downstairs as well, and the warehouse. And one of the things we learned during Irene that did during Sandy, anything that was in the warehouse, if we had time during evacuation to get it out of the warehouse, we did. Because a lot of new equipment had been coming in. The timing is just, it was the end of one fiscal year, the beginning of another fiscal year, and all this new equipment is coming in. We were able to save most of it by getting it to upper floors at Manhattan, because the only floor that was underwater was that basement ground floor. Also part of the $207 million, Secretary Shinseki, to make us state-of-the-art, said we will modernize every inpatient unit at the Manhattan site. Even though they were not touched by water, he said, if we're going to do this, we're going to do it right. So in summary, know your site's vulnerabilities. Every site is different. Mine was very different at Manhattan than it is at my Brooklyn or Queens site. Know it, and don't be afraid to trust your gut instinct. Where are you going to put your patients and staff during a disaster? The tabletop exercises are fine, but when the rubber hits the road, do you really know where they can go, and have you worked out the systems to do it? Communication. Do you have redundant ways of communicating with staff and patients? And transportation. When you're fighting with everybody else to move patients, do you have a valid transportation system? And that ends it for me.